Thanks, Oma. So again, for those of you that are just joining us, welcome to the SOPHIA webinar series for fall 2024. We've got two excellent presenters from the Minnesota Department of Health. I will give just a quick bio for each of them, and then I will turn it over to Audrey and Jeanette for their presentation today. So Audrey Hansen is an MPH. She is the State Health Assessment Project Lead and Project Manager at the Minnesota Department of Health in the Community Health Division. Jeanette Raymond has worked for the past 3 statewide health assessments at MDH and has worked on implementing a health and all policies strategy in the last 2 state health improvement frameworks. So Audrey and Jeanette, thank you both for being here today, and I will hand it over to you.
Great, thank you. I am just pulling up slides here. All right, is everyone able to see those? I think so. Great. All right. And I'll just make sure I have kind of notes up here. So thanks again for the opportunity to present to you all today on Minnesota's recently released statewide health assessment, and more specifically, the newer policy profiles that we developed for this assessment. As we were introduced, my name's Audrey Hansen, and as Audrey was so kindly to say, I'm the project lead for the assessment, and I'm presenting today with my colleague Jeanette. In thinking about our presentation today, we thought of these 3 kind of learning objectives and what we hope you all can come away with after our presentation. First, maybe that understanding of how policy profiles might be able to elevate systems impact on health, maybe more so again than looking at individuals' health, behaviors and outcomes in an assessment. Learning about the components and our process for developing a policy profile. So what were the pieces that we pulled together? And then hopefully near the end, we will have a chance to maybe practice and apply some pieces of this template, or again, those components in thinking about how it might apply to your work. So I think with that, I will pass it over to Jeanette.
So before diving into the policy profiles, we wanted to give some background around health and all policies in Minnesota. And this will not be totally comprehensive, but it does relate to the work associated with this. So next slide. So Commissioner Ed Ellinger and Assistant Commissioner Jean Ayers, and this is 2 commissioners ago, developed this triple aim for health equity, which elevated sort of 3 strategic approaches to advancing health equity. While public health has a history of advancing policy that save lives across sectors like seatbelts or smoking bans, things like that, with the hospitality industry, with the airline industry, et cetera, Commissioner Ellinger's administration was more interested in the impact of things like wages, marriage laws, incarceration policies, et cetera, conversations that public health had not always been part of. And so some of this is taking you back to about 10 years ago. It's not that we weren't doing those things. They wanted to sort of advance that practice more thoroughly. Next slide. And then, yeah. So the way that this was done, first of all, was through the Healthy Minnesota Partnership. So this is in Minnesota, the statewide health assessment and the statewide health improvement framework are developed under the direction of a cross-sectoral partnership that's led by the Department of Health, but involves many, many different kinds of groups, including other government agencies, community groups, advocacy groups, et cetera, and organizations impacting for those who are most experiencing health inequities. That was another one of our focuses. MDH is part of this partnership, and our assistant commissioner is the co-chair of the partnership. It's not an advisory group. It's really designed to be a partnership where people come together and do this work. So the partnership adopted health and all policies and expanding the conversation about health as its primary strategies between 2012 and 2023. And right now we're refreshing our statewide health improvement framework. So they may adopt it as a strategy moving forward, who knows? But I want to say that there's a link between these two strategies of expanding the conversation about what creates health and health in all policies. So next slide. So in some ways, it is very difficult to advance health through incarceration policy, marriage policy, et cetera, if we don't expand that understanding about what creates health. So this was our sort of strategy. We both did a lot of what we called narrative work, or people might know it as mental model work, where we're really expanding that conversation about health. If you ask people what creates health, they'll say individual behavior and access to healthcare. And those things are really important, but we were trying to get at what's the relationship between wealth and health? What's the relationship between income and health, transportation and health, et cetera? And once we had developed that understanding a little bit more firmly, then our members could actually advocate for policy and shaping policy in ways that would support health. Next slide. So I will say that our story about what creates health has changed over time. In 2012, which is on the left-hand side, our assessment was radical at that time because we led with the conditions that created health in our statewide health assessment. So this was really related to transportation, housing, education. A member said to us, if we really believe that it's these conditions that create health, then we should actually lead with that. So in 2012, our statewide health assessment led with conditions, had a section on health behaviors, and then had an appendix on health outcomes. In the 2017, the Healthy Minnesota Partnership said, we want to really look at what are the connections between social, economic, and environmental conditions and health outcomes. So we tried to, in the 2017, you can see it's an evolution of thinking where we really tried to link those conditions, those health outcomes to conditions through data. And then for the 2024 assessment, the partnership really wanted to look at systems. Again, if we believe that systemic racism or systems have an impact on people's health, what kind of data do we have that actually demonstrates that? And I would say sometimes it's how we frame our data. Next slide. So we sort of, so part of this is for people to imagine or identify a system or structural solution to improve health. We actually need to shine the light on those systems and structures. And so in the development of the SHAW, a few key questions we were trying to ask were, if health inequities are rooted in systems or structural conditions, how do we elevate data that demonstrate this? And how can the SHAW data shine a light on the systems and structures that impact which communities are healthy and which communities are not, and why? A major challenge in the public health data is that it's often collected at the individual level, and so it doesn't allow us to sort of see those systems and how they're operating. So we sort of looked at what does it mean to provide systems level data? And we actually worked with our partnership in considering a variety of approaches. We looked at data from past assessments that had a systems lens or that could be framed through a systems lens. For instance, in our 2017 assessment, we had the rate of introduction of infant formula in hospitals to WIC clients from different demographic groups. And what that showed was that immigrant groups were getting, like 75% of East African immigrant groups were getting introduced to infant formula, where like 25% of the white population. And this is in WIC clients, so they're all low income. And so it really showed us that there was something in the hospital system that was driving that behavior. But you need to frame the data that way, because if you don't, then we could say, well, it's just because individual people are asking for formula, and so we just need to educate them more. We also asked our partners to look at systems level data from their own data set, so Department of Transportation, Department of Corrections, and helping them think about how they might frame their data in systems ways. And where we landed was for this assessment was to feature policy profiles in 3 of the 4 sections of the assessment. But again, the basic idea here is if you don't show what the impact of those systems are, then people will default to individual behavior or healthcare solutions. Next slide. I think I'm almost done. I did want to just add before handing it back to Audrey is that in case people tell you you're getting out of your swim lane, which can happen, the Public Health Accreditation Board and also the Foundational Public Health Responsibilities is really emphasizes in different places the skill of working collaboratively to inform the prioritization of policy strategies and interventions. And the skill is to be able to effectively inform and influence policies that go beyond public health policies to physical environment, et cetera. You can read this. So again, there's backing for you if you get a little pushback within your own department. And then I think I'm going to hand it over to Audrey.
Yeah, thanks, Jeanette. So that was some of the broader background. A few more slides before getting into our process about what's actually in this most recently released assessment. This most recent assessment is divided into 4 sections: people, opportunity, nature, and belonging. And as Jeanette just explained, each of these sections really look at a variety of different topics and how conditions and how those impact our health. On this slide as well, you can see the 3 topics for the policy profiles of this assessment, and those include paid family and medical leave, tree canopy coverage, and then universal broadband internet access. Looking closer at these policy profiles, this slide will just share some examples of a data piece that we included for each of these. So for that paid family and medical leave profile in the opportunity section, we looked at, again, medical leave and its impact on health, and thinking about showing that at the time of writing, actually in 2023, even more than 1/3 of working people in Minnesota had no access to paid time off when sick or caring for a sick family member. For tree canopy coverage, which was in the nature section, we looked at tree canopy coverage across the state, and again, its impact on health. And an example of data that we included for this profile was that the proportion of tree cover in the 7-county metro area in the state of Minnesota ranged as low as 0% in some parts of Minneapolis to as high as 67% in parts of North Oaks. And we did include some maps in that profile as well. And then finally, in the belonging section, we looked at that universal broadband internet access, again, looking at its impact on health and how it helps us connect to each other and how that impacts our health. But this section, again, an example of data from it shows that across all of Minnesota, 92% of Minnesota housing units can access wireline. However, only 74% of rural Minnesota housing units have access to standard speeds. And actually only 63% have access to the state's 2026 broadband speed goal. So again, just thinking about who is being impacted or having access to these different policy areas. But now that we have kind of that broad understanding, we wanted to walk through, again, our process for developing the policy profiles. We did create a handout that we can hopefully share afterwards that walks through this process as well, and also includes some resources that we leaned on in crafting kind of the different pieces for our profiles for this assessment. On these slides, we'll also be referencing the paid leave profile as an example.
So Audrey, there's 2 questions in the chat.
Yeah.
And I do want to clarify that we utilize data from our partners, from MDH, and about half of our data was from partners. So we, except for the assets pieces of the assessment, we actually used existing data. So there was a question about what tools did you use to assess the percentage of tree canopy? So that would actually be a question for our, I don't know who you worked with on that one, Audrey.
Yeah, we worked with some folks in our environmental health division, and I think we'll also be sharing the profiles themselves. I know I included a link to the very long assessment document itself. So the sources for those are on there, but if anyone has questions after, I'm happy to connect. We worked pretty hard with our Office of Environmental Health and Data Strategy and Interoperability to think about how to visualize where tree canopy coverage is happening across the state.
And the prioritization question is the same. We work with our internal and external partners to prioritize, because really even our assessment is too long. So having a short assessment actually lets people engage with it more. And so we help set those priorities with partners and our internal folks. But now go ahead. I think
okay.
That answers the.
Great. All right, so at a high level, these are kind of the steps to our process that we'll be walking through. First being identifying the policy area for your profile, then defining the issue or kind of area it's addressing. Then we go through a section about why the policy area matters for health, and again, kind of make how these systems, how policies might even be upholding systems and structures that are impacting our health. After that, though, we do actually include some systems and policies which are shaping the issue itself. Then delving into if there are some of the inequities that might be actually captured by some data and exemplified around the issue itself, and then any recent policy responses that might be surrounding the issue, which we'll point to again in our example. But first, thinking about how to identify the policy area you'd like to focus on, as Jeanette and I both walk through in kind of those beginning slides, this most recent statewide health assessment really wanted to shed light on how those systems and upstream factors are impacting our health. So when thinking about this, we really would recommend looking at conceptual models, thinking about, again, the Bay Area Regional Health Model here, socioecological model, any of those that, again, point to what are those upstream areas that are impacting those health behaviors and health outcomes that your kind of program area or anything might be working on. Specifically for our process, we identified topics with help, especially from the partnership, as Jeanette described before, and some of their prior work, especially some of that narrative work and materials that had been created beforehand. And then, as Jeanette just alluded to as well, the whole assessment is a really collaborative process with lots of different partners involved. And so through subsequent meetings and activities, we were able to really narrow down what are the topics, 3 topics for this assessment going to be, and how do they kind of exemplify and fit within our structure for this assessment, and provide those examples of how policy areas are impacting health. I'll also mention here that since the assessment's been released, there have been additional topics that have been identified through conversations with MDH staff and across our department, which is great to see people kind of, again, latching onto this idea and seeing where this can shed light. And some of those topics include childhood immunizations, rural transportation, voting, thinking of civic engagement. So those areas are also being explored. The next, or kind of the first piece to the profile itself then, after identifying your topic, is defining the policy area. And what we tried to do here is use 1 to 2 sentence. So thinking what's like brief and going to get across really clearly to our audiences what this policy area is. For this, we do recommend, and what we pulled from is looking at both the public health scientific literature and also legislative or government agency sources. However, we did want to distinguish that we weren't trying to take language from a policy proposal or like legislative language or law itself, trying to simplify that. So there aren't any also like specific numbers or requirements and definitions, but something really simple and just a couple sentences that defines what we're talking about. In the picture down in the lower right, you can see the example from that paid leave profile where the Minnesota Department of Employment and Economic Development defines paid leave as that policy or program that provides paid time off when a serious health condition prevents you from working, when you need time to care for a family member or a new child, for certain military-related events or for certain personal safety issues. So giving that context too can be helpful of what's the definition in your area. The next piece is why the issue matters most for health. So here we tried to describe, and again, tried to pull from the literature where we could explain those pathways, how a policy area is impacting our health. And in the example shown again from that paid leave profile, we explain how paid sick and paternal leave impacts our financial stability, which we have even more information in the assessment itself. I think Jeanette had alluded to earlier too, about how income and wealth impact our health overall. And then also our ability to care for ourselves and also heal ourselves and others, having that time off. This could also be a place where a graph or visual might be shown, or an opportunity to, again, kind of layer different data sources and do some analyses. For example, looking at access to or benefits from a policy area, and if there's any increases or decreases in a health behavior outcome. For any kind of epidemiologists or kind of research scientists on the call, I'm thinking of, again, what are those layerings of data that might be explored, though knowing that we don't want to kind of oversimplify anything. And we also know that sometimes, again, there's limitations on what data might actually be available. Next, for the profiles, though, we did look at what are some of the systems or actual policies that are at play around this area. And again, how people overall might be currently being impacted or not being impacted by them. So we'll stress here that it's also really important to show audiences that policies happen at multiple levels. So this can be a really key area to point out. Most people might be familiar with maybe those state, federal level policies and maybe might recognize how they might impact health, but it's a good opportunity again to think of what are the local policies happening? Are there organizational or institutional policies around an issue that again might be impacting health? Some examples from the paid leave profile again is that we pointed out the National Family and Medical Leave Act, as well as the most recent COVID rule that took place.
I just want to point out here that one of the pathways for public health is to start policy at the local level and then move it up to the state and federal level. So if you think about tobacco, a lot of that was done at the local level first. And in Minnesota, we actually had 4 or 5 municipalities that passed paid leave, maybe counties too, at first, and then it became a statewide policy. So it's important to highlight that local level where it exists.
Yeah. I think we have a slide too that shows coming up that will show where those local ones first came in and then the state one followed, but exactly the case that you're able to kind of show with these profiles. The next piece that we included in each of the profiles is look at any of the inequities that we had data on that might be occurring again around a policy area. So this might be thinking about, can we disaggregate any of this data too, looking across race or ethnicity, gender, class, income, geography, disability status, more, any other ways to kind of slice the data and highlight how maybe groups or populations, communities, people might be benefiting or not benefiting from a specific policy area. And again, shedding light on how are these systems and structures maybe upholding inequities in our communities that then further impact our health. For the example profile, we show data from between 2016 and 2020 that show how Minnesotans are using paid leave after childbirth. Specifically that people of color are taking less paid leave, and then included the factors influencing that ability to take time off. And then the last piece that I will point out here is what are any current policy profiles or policy proposals or any legislation that's either maybe currently under review or recently passed related to this area. In Minnesota, we were able to highlight, like Jeanette mentioned, both local cities passing measures beforehand, and then the most recent state legislation that passed very close to the time of this assessment's release. So this also, like Jeanette mentioned, just shows those pathways for local policies laying the groundwork, as we know can be the case for other policy areas as well. Before maybe pausing for any questions, or again, maybe checking the chat, this was just some of our guidelines that we kind of held ourselves to when creating these profiles as well. We found them helpful. First, we did try to limit ourselves to 2 pages. As both myself and Jeanette have mentioned, the assessment itself is really long, and we acknowledge it's a lot of information and might be even overwhelming to some audiences to dig into. And we also know that likely even around these policy areas, there's a ton of information that surrounds them. And you could go into detail about kind of all these, even each of these components. But what we really tried to do is distill down to what's the most essential descriptions and examples for audiences to understand, again, that linkage between how are these kind of system level policy areas impacting our health. I will point out that in other places in our most recent assessment, what we tried to do, given the kind of more recent availability of all these data dashboards, or even links to some of the new strategic plans or frameworks or initiatives that are going around these topics, we tried to provide some links to those for audiences so that they had those resources readily available to them and could go reference them if they wanted to dig in and learn a little bit more. The second piece, though, to this, along with condensing down content, is that we wanted to stress, and we really held ourselves to trying to use plain language. I think this goes to that, again, describing or definitions of the policy area itself. Point 2 is making sure things are readable and understandable and not getting bogged too much down in some of that policy language, so to say. Also, we tried to use graphics wherever possible. I know I've mentioned some maps previously, and there's one pictured here as well, showing again where some of those local areas passed some of the safe and sick time policies. But we found maps to be really helpful and had conversations, I know, with subject matter experts and again, the partners that we worked with in creating these, thinking about how these can be really helpful for people to recognize, oh, I live here, and this is maybe how helps them think about how this may or may not be impacting them. I can actually maybe take a pause point there, see if there's not any questions in the chat.
Jeanette has been answering them in the chat. So
Great.
There's nothing sort of pending there, but Jeanette, did you want to add anything or add any clarifying points?
No, I mean, Kingsley had an interesting thing. I can't see a picture, no, he, she, they. I think considering land use or land coverage maps of the city, specifying percentage of canopy cover would open up more research possibilities and combining with public health data. So I will say the city of Minneapolis did that in their latest climate equity plan. And so, so it is a really good idea. And what I wanted to say, and Audrey will make this point later, is that an assessment is really meant to open up a conversation. It's not meant to answer all the questions. So this is, if you think about this approach at your local level, I think Kingsley's point is really well taken. You can actually get a little bit more granular when you get to that local level. So, and then it opens up the conversation. Like in our city, there's definitely a link between tree canopy, and I live in Minneapolis, and communities that were redlined in the, the 20s and 30s or whenever that happened. And you can see there's less tree canopy in those neighborhoods, which actually leads to greater heat in those neighborhoods, which leads to more heat-related illnesses. So there's the through line is possible to tell. So thank you, Kingsley. I don't know if you wanted to add anything else.
Great. Any other questions? I think I see a hand up for Leslie.
Fine. Thank you for recognizing me.
Yeah.
I guess you would call me a woman of color, but I identify as Black Native. And the canopy has been an issue, not just over in North Minneapolis, but South Minneapolis. And being a native Minnesotan and Minneapolisan, I've seen the trees disappear because of the illnesses that the trees have. And some of them get taken care of where it's too late, so they have to be removed. My issue is when you say the inequality when it comes to our health and disparities. Minneapolis, South and Minneapolis have those polluters, the factories and things like that continue to barbar our health. And it's not, really being addressed. We go to the hospital and things like that. So we were able to manage to close Northern Meadows and now Smith Foundry. There's money supposed to be allocated to North Minneapolis residents, but not those that lived there prior that had health problems, only if you get tested and you have opened your home to be tested. And that's the only way that you get money for allocation, where that's only a small fraction that does not cover your medical expenses. And until that changes, you'll still always have the disparities in our communities, as well as when you do go to the doctor, you deal with racism. Me personally, I dealt with it where nurse practitioners told me they were doctors. There's a big difference in the education and the level of what is accepted to be called a doctor and a nurse practitioner. And so the lack of communication and things like that, and me being Black and 67 and educated, I still deal with racism when I come to certain doctors' offices, which made me change doctors 4 times within a month because of the racism. And so until the doctors and the caregivers that are in these facilities get educated and stop being racist when people of color come in, then, a lot of people don't go get health care because of it. And so it's a horrible situation to be in when your doctors make racist comments to you when you're just there to get your body checked out. And until those things change, it's always going to be disparities and inequality in the health field when it comes to the health and well-being of the residents that live in Minneapolis. So until some of those things change, I know Hennepin County Hospital put in place where they're making efforts to change, but it's still there. And
Thanks
that's
for
all I
that.
want to
Thanks
say.
for that
Thank
comment, Leslie. Yeah, Audrey or Jeanette, did you have a quick response?
Well, just Leslie, you're talking about the impact on the individual, but there's actually those hospital policies that are not holding their own staff accountable for behavior that we should expect, which is treating everybody with as a human being and in a culturally competent way. So you can sort of see that part of the trick here is, or not the trick, part of the process for us is thinking about what are people experiencing and how do we roll that up into a systems level or a policy kind of approach. Kingsley, did you want to add something?
Yes, greetings, everyone. Interesting research and quite valid points made by Leslie. What I wanted to contribute about is what strategy have we actually considered in the health policies? I see the policy profile on paid family and medical leave, and when I saw that during your presentation, where my thought went to was on short-term employment and unstructured workers from local Minneapolis community, and how are they also benefiting in this sort of health policies, and how do we in such a way assess a couple of organizations who are quite small in size, how they are implementing some of these policies, especially for their local or short-time employees?
Mhm. I do not know that level of detail, Kingsley, about the short-term employees. I will say how how this is sort of implemented both at this is at the policy level, not at the organizational level, is that people in the partnership and others advocated for paid leave through a health lens. So in Minneapolis in particular, it was very apparent who was benefiting from paid leave and who wasn't. So low wage workers are the ones that are not benefiting from paid leave as much. It's actually workers who work for the state health department or the city or for big corporations that all get very generous benefits. So people were able to advocate that on those things and talk about the benefits of paid leave to get the city policy done. Now, the implementation of the policy is sort of a blunt tool. So you're quite correct. Like we can pass these policies, but will they be implemented and how will they be implemented? And that's sort of that's the secondary work that happens. So I just want to say the issue you're raising is really important. And at this statewide health assessment level, we're just trying to get that conversation going. So I hopefully that's helpful.
Yes, thanks very much.
Yeah, I think I would just emphasize that point to these profiles. And I see a great question. I think it's from Alicia of who is the intended audience. We actually have a list of multiple potential audiences for the whole assessment I think it's near the end of our webpage, and I can share the link again as well. In thinking about, this is a lot of information, and what conversations can these start, and how can it maybe help people, again, who might initially think of, oh, health again is our individual kind of behaviors in that healthcare system. That's all that's kind of interplaying and impacting my health. But can it help some people shift their mindset and think about, wait a second, I'm not able to access certain things, or I'm being treated maybe also, my experiences are probably being impacted by some higher level or those upstream factors. And how can we have conversations about how we can change those and things like that. So complex, we understand that too. And I think that was the challenge behind these two, and might even be parts of these lessons learned as well. I can certainly pause again too for maybe some more questions. Or go ahead, Jeanette.
The intended audience for these policy profiles, our first audience was the partnership itself. And because FAB requires there to be policy objectives in our statewide health improvement framework, we were giving examples of things or ways that we might approach policy. So that's number one. The second was local public health departments and hospitals in Minnesota who are doing local assessments and hospital-based assessments. We wanted them to see this as something they could include in their own assessments with sort of more of a local angle. And then others, we were generally trying to expand the understanding about what creates health, which I mentioned earlier, with our partners, with potential partners, with others who are interested in advancing health, sort of helping them see that while, as Leslie said, we really do need to hold healthcare providers accountable for providing good services and appropriate services in ways that everybody can be felt like they belong and they're welcome, that there's other things that people can do, sort of like around tree canopy, around climate change, around paid leave, around wealth enhancement. I mean, there's lots of ways that people can enter into and support the health of communities. So, but you can sort of see our first audience was our partnership itself, others that do assessments. And then, as Audrey mentioned, in the assessment, there's a chart with different groups and how they might use the assessment.
Great. I'm wondering if it might be helpful. We'll walk through these lessons learned and then continue. I see some more questions coming in from the chat or any other questions we can address, but some might be even answered through some of these lessons that we learned. I think this might be related to some of what we just talked about, but I think one of the key takeaways for these profiles too is that they're meant to be educational, again, and show how the systems and upstream factors are impacting our health. But we really walk the line. They're not intended to advocate for a specific piece of legislation or policy. This was important for us to keep in mind when drafting the language and ensuring we were maintaining kind of that neutral voice. But again, it's really that first piece of understanding those pathways and how, again, those upstream factors may be impacting our health and starting the conversation on the education side of things. We also found it really helpful, I think we mentioned before, to involve subject matter experts and partners working really closely around these issues across the development of them. So they helped identify data sources, narrow down what the topics specifically were, and also while helping review, as my third bullet there says, kind of edit. It helped us both with condensing, but also just making sure that we were being really clear about what the storyline is through these profiles and what pieces were most important to include. I think I'm passing it to you, Jeanette, for the next three.
Yeah.
Kind of
So
lessons learned.
I mentioned before that we really wanted to provide examples for local and hospital assessments so that they might copy this as part of their local assessment. We do consider partners' needs and ideas for more profiles. So after this, after we did the assessment, we actually worked with another MDH program that is looking at things related to the policy environment. And so we sort of thought, well, how could we contribute to that? So we got some more ideas. I did mention in the chat that the tree canopy, the partnership steering team really wanted to look at a climate change kind of indicator. And they actually chose this one because they thought it would be helpful both in an urban setting and small town and rural setting too. We didn't get into forestry policy, but if we had known more about that, that could have been part of our tree canopy conversation. I think we did mention it, but we don't know that much about it. I did want to say some policy areas may present risks. So in particular, the one on childhood immunization was sort of dicey because the conversation around immunization now is very politicized. Our own department has a policy agenda around childhood immunization, and we don't want to get too far afield from what they're doing. But the third is when you think about it at a local level, like one policy area might be changing immunization expectations at a local school district level, but then it could also go the other way. There could be really low expectations driven by community input for like reduced vaccinations at a community level. So when you're thinking about this, it's not just what we think might be positive, but what might be the negative consequences of it as well.
Yeah, thanks, Jeanette. I know that might relate, Alicia, to your comment there. And I saw we'd be happy to connect with you or others who have additional questions and sharing kind of what we learned, especially to that point, and how some of those policy areas may present risks and how we navigated that.
I just want to say one other thing about choosing policy areas is that in our previous work before this assessment, we would look at what policy areas are really in the conversation around the state, like we knew they were coming up with the state legislature, or for instance, burdensome debt was one that was coming up. It wasn't a state legislator issue, but payday loans or student loans, like they were really coming up in the conversation. So we looked at those. So that's one thing to do too, is not just pick some obscure policy issue that nobody cares about. It really is helpful to provide fodder for people who are trying to advance policies in ways that will support health. And you'll only know that if you work with them. But that's more of a strategy kind of thing.
And I see another question. Apologies if I'm pronouncing your name wrong, from Nidhi. Is the childhood immunization policy available online for review? I don't believe it is yet. It's still under development.
Yeah. And I'm not 100% sure what we're going to do with it, again, because there's so much internal expertise in It's challenging when you have local and state, and your statewide folks wants to do some things, but local conditions might not allow it. I think we might back out of that one. So that is an excuse, but.
Any other questions or kind of comments before? I know we have about 13 minutes. We can move into practicing or any other discussion, but I really welcome any other questions. This has been great to share with you all and hear how others are thinking about using in their work.
I just want to respond to Leslie's question. Is that the one you were going to lift up, Audrey?
I was actually going to point out part of Alicia's question, but go ahead, Jeanette.
Well, Leslie, so your question is a really big question about how do you hold a hospital and clinic accountable for racism that exists? And it's very difficult to do as an individual. So I think one thing is to maybe join with others in your community who are trying to impact the behavior of your clinic and your hospital. That's number one. Number two is look at their website, look at their value statements, their own policy statements. You might be even able to find some policies related to this, especially with organizations that are focusing on diversity, inclusion, equity, and justice. And then actually go to them and say, you're not actually living up to your own organizational policies and principles. So that's a very generic way to do it. I will say that as we are developing policies, priorities for our statewide health improvement framework, this very issue that you brought up is a very live in the conversation. And we are actually going to be discussing what might we do at a statewide level to address this. So if you're interested in connecting with that, please connect with me or Audrey after this. So.
Thanks, Jeanette. The other question that I think is lingering in the chat still, Alicia asked about, and you've touched on some of this, who is the intended audience for these profiles? I think you talked about that. Did you intend for lawmakers to act on them? Did you run into issues with being told it's too political for a public health department?
I don't believe we did. I don't know, Jeanette, if you've had any more context or conversations, not around the three topics that were the three that are in the assessment. We didn't. The childhood immunization one that Jeanette just mentioned, and potentially any others hold that risk, maybe. But I think the childhood immunization one is the one that comes to mind that has had the most discussion around that.
For us at the state level, we want to make sure that anything we're talking to aligns with whoever the current governor's policy agenda is. And it doesn't mean we have to support a specific policy, but we can't get too far afield. And I will give an example, but conditions change. So our partnership was really interested in looking at the policy related to driver's licenses for undocumented residents of our state. There's a lot of data that shows when they can get driver's licenses, they, like traffic accidents go down, blah, blah, blah. So, but we were told that that was not something we could promote because it wasn't in the governor's agenda. And this was a number of years ago, so I don't need to mention the governor or anything like that. But so, yes, there are political considerations, and there's so much potential in this approach that you can align with your political leadership's goals and still advance health and all policies through this approach. Hopefully that answers the question.
I'm not seeing any other questions in the chat. Audrey, if you wanted to give us the practice opportunity. Thanks.
Yeah, in these last couple minutes, we thought it would be great. Okay, we've also know that there could be many, many topics that we might choose as a group. So we tried to give maybe a prompt here to help us narrow one down, and then apply that piece of maybe identifying policies at different levels that are interacting. But first, and I'm going to move over a Padlet link here, our question to kind of prompt us to think of an area or topic for this would be, in the face of another pandemic, what policies do we need to have in place to support a more robust response? So I'm going to move my screen over here and make sure to share the link to the Padlet in the chat. And if this doesn't work, we can kind of pivot to using the chat as well or talk, but it looks like someone is in here, which is great. We'll give maybe just a couple minutes to think on what topic we might want to explore together. And if anyone's having trouble accessing the Padlet too and wants to just come off mute, I'm happy to record it onto the board as well.
Okay, I was wondering, what about housing? Because wouldn't housing and the way the condition of the house, the air that comes in and out by the quality of air, wouldn't that affect the house? So housing policies, would that have something, well, that would have something to do with the health?
Yeah.
That's a great one.
Also during the pandemic, I don't you remember there was a moratorium on kicking people out of their homes for lack of rent and foreclosures. And that was because if people could stay in a community, they would be much better connected to support for addressing the pandemic. So housing in a variety of ways.
Great. And so what I'm seeing here on the board is data exchange, guidance, public health data modernization efforts to support coordinated response to public health crises, access to healthcare in non-traditional settings. It looks like some context of in Michigan, they're set up COVID testing sites in non-traditional settings like churches, barbershops, and continuing to lead on that infrastructure. School attendance or broadband access for virtual schools, and then housing quality, or housing quality of housing. And I also see guaranteed income as one, the 5 here too. So I think pausing here so that we can kind of delve into, again, what is happening at maybe different levels of policy. There should be a way to, oh, and it might have left this one to see if there was going to be a way to kind of like these and see if there was one. But I guess if people could write in the chat which one they would like to explore, we can see which one we want to move forward and look at the different levels of policy. I also see there's one been added, school attendance, broadband access, or no, this one's broadband access is kind of a second one there. I did see 2 for housing income, 1 for broadband.
A mixture across the board there so far.
Mixture across the board. I am seeing housing for kind of 3. The quick synthesizing and like calculating in my brain skill of like, okay, what's our top topic? Just for the sake of time, I think we'll move housing over onto our next slide. So thinking about housing, and we could keep it broad, or we could kind of focus into quality of housing, as I think it was Leslie who mentioned that up. What are some of the maybe local, organizational, statewide, federal policies? Thinking organizational, are there kind of like institutional or organizational for maybe housing quality groups at play or anything like that? But just brainstorming the different levels of policies that might be interacting in this area.
Or maybe people could just come off mute and say them.
Mm-hmm. I see local program for code compliance, based on external quality. I think that's that survey.
Updating your local zoning code.
Yep. Yeah, so zoning policy is a big area of policy.
Any others that people feel kind of worth mentioning these last couple minutes? You can see,
You know, foreclosure policy, you know, like that's not quality of housing, but you know, like what are the processes for foreclosure and who determine those and who do they benefit and who don't they benefit? For the broadband one, you're in luck because that's one of our 3 policy profiles. So you can
there might be some
see how we
examples.
frame that one. Because broadband's sort of interesting because a lot of how broadband is distributed is determined by corporate policy. And of course, state and federal policy provides some guardrails, but you know, if they can't make money off of it, you're good luck.
Anyone else have anything they'd like to raise as an example or any last questions?
Well, I just want to thank Audrey and Jeanette for this excellent webinar and for all our participants for some excellent engagement today. We really appreciate your time. Audrey did tell us that this is just a preview of an APHA presentation. So if you are heading to Minneapolis for APHA next month, you can find her, you can ask more questions, and I think maybe get a little bit more information as well. And then I'm going to hand it over to Oma, for our SOPHIA coordinator, for just a couple of announcements very quickly.
Yeah, real quick before everyone leaves, thank you so much, Audrey and Jeanette. That was really interesting and engaging, and we all appreciate that. I'm going to send out in the next couple of days a link to the recording of this, and I'll send out Audrey and Jeanette's contact info in case you missed that in the chat, and then the handouts that I have from them. And if you like today's content, you can join SOPHIA. I'm going to put a link in the chat. We'd love to have you as a member. And our membership dues help keep the lights on and keep things like this happening. So stay tuned for more SOPHIA events in the future. That's all. Thanks everyone so much.
Thank you.
Thanks.
Thanks.
Bye-bye now.
Bye.